Hello, this is Dr. Anka Abram, Professor of Radiology in the Division of Nuclear Medicine at University of Michigan in Ann Arbor. I will present today functional thyroid imaging for the AUR core curriculum lecture series. My disclosures are none. The learning objectives of this lecture are as follows. We will discuss how to define hyperthyroidism and thyrotoxicosis. I will present the approach to imaging thyrotoxicosis. I will describe the notion of productive versus destructive thyrotoxicosis. I will present the approach to imaging thyroid cancer, and we will utilize the presented information in the appropriate clinical context to improve patient management. In functional thyroid imaging, there is an essential terminology that has to be used, and this consists in the clear differentiation between the notion of hyperthyroidism versus thyrotoxicosis. Hyperthyroidism is characterized by excessive production of thyroid hormone by the thyroid gland. In essence, it defines an overactive thyroid gland. On the other hand, thyrotoxicosis is a syndrome characterized by excessive quantities of thyroid hormone present in the circulation, which can be from any cause, such as the overproduction of thyroid hormone by the thyroid gland, or excessive oral administration of thyroid hormone, or leakage of preformed thyroid hormone from the thyroid gland, as it happened in the setting of thyroiditis. Regarding thyrotoxicosis, the functional imaging of the thyroid gland is precisely utilized in order to differentiate productive versus destructive thyrotoxicosis. Productive thyrotoxicosis is actually imaging of a hyperfunctional thyroid gland, such as in Graves' disease or toxic multinodular goiter, while destructive thyrotoxicosis is imaging of an inflamed thyroid gland which is leaking thyroid hormone due to cellular damage and inflammation. So these thyroid scans with technetium-99 pertechnetate or iodine will help us differentiate productive versus destructive thyrotoxicosis and help us pinpoint the accurate diagnosis for correct treatment. Productive thyrotoxicosis or hyperthyroidism, the most common etiology is Graves' disease, which is due to the presence of an autoimmune thyroid condition characterized by the presence of thyroid stimulating hormone receptor stimulating antibodies. Less common etiology of productive thyrotoxicosis is toxic adenoma and toxic multinodular goiter, which are due to an activating mutation in the TSH receptor leading to autonomous thyroid function. Also common but less commonly encountered is this entity of hashitoxicosis, which is actually an overlap between Hashimoto thyroiditis and Graves' disease. As we know, Hashimoto thyroiditis and Graves' disease are on the same spectrum of thyroid autoimmune conditions. Could be described as two sides of the same coin, which is thyroid autoimmune disease. Therefore, we can have both presence of cellular autoimmunity with lymphocytic thyroid infiltration, characteristic of Hashimoto, and also the presence of anti-TSH receptor stimulating antibodies, characteristic of Graves' disease. So there is such an entity as hashitoxicosis present due to autoimmune thyroid condition involving both cellular thyroid autoimmunity with lymphocytic thyroid infiltration and the presence of stimulating antibodies on TSH receptor. Less common causes of hyperthyroidism are the presence of a trophoblastic tumor, choriocarcinoma, leading to circulating human chorionic gonadotropins that will stimulate thyroid function at the level of the TSH receptor. Even less common are familial gestational hyperthyroidism with TSH receptor which is hypersensitive to the action of human chorionic gonadotropin, and also type 1 amiodarone-induced thyrotoxicosis, which is due to the increased iodine load in a patient with a background of multinodal goiter, leading to thyroid hormone overproduction and thyroid autonomy. We have three major radioisotopes that are used for imaging thyroid gland. The most commonly used is technetium-99 pertechnetate. Also iodine-123, it's used for thyroid scintigraphy, while iodine-131, it's used for therapeutic application such as thyroid gland radioablation procedure for definitive treatment of hyperthyroidism, and also it is used for treatment of thyroid cancer after total thyroidectomy. However, in the setting of diagnostic imaging, iodine-131, it's used for thyroid function quantification in the setting of iodine-131 thyroid uptake testing. So these are the main characteristics of the radioisotopes used in functional thyroid gland imaging. So technetium-99 pertechnetate has a physical half-life of 6 hours, has pure gamma emission of 140 keV, which is suitable for imaging with low energy high resolution collimator, producing imaging of exceptional good quality. Iodine-123, sodium iodide, it's isotope with a physical half-life of 13.2 hours. It's a pure gamma emitter with photon energy of 159 keV. Therefore, we can use low energy high resolution collimator for thyroid scintigraphy. Iodine-131, as I explained before, it's both a gamma and a beta emitter. The gamma emission is a 364 keV, which is used for thyroid uptake measurement, and also it's used for imaging thyroid cancer after total thyroidectomy. And the beta emission of 606 keV is the therapeutic beta particle emission that it's used for radioablation procedure and also for targeted treatment of thyroid cancer metastasis. The physical half-life of iodine-131 is 8.1 days. And for imaging iodine-131, we need high energy collimator that is windowed at 364 keV. It's centered at a 364 keV window. Regarding the comparison dosimetry, it is obvious from this table that technetium-99 pertechnetate has a diagnostic dose of 5 millicurie, which is routinely used for thyroid scintigraphy, has the most favorable dosimetry for the thyroid gland, while the thyroid scan produced with iodine-123 has a higher thyroid dosimetry, although the activity prescribed for thyroid scintigraphy is only 0.4 millicurie or 400 microcurie. As I explained before, iodine-131 it's used only for thyroid uptake in patients with an intact thyroid gland, and the thyroid uptake measurement requires a minute quantity of iodine-131 of only 7 microcurie, and even at this dose the dosimetry is higher significantly higher as compared to technetium pertechnetate, and also higher as compared to iodine-123 due to the emission of the beta particle. Therefore, iodine-131 is not used for thyroid scan acquisition in patients with an intact thyroid gland. Practically, this is an isotope that is either used for thyroid uptake quantification in patients with an intact thyroid gland, or it is used for thyroid cancer imaging after total thyroidectomy. So, thyroid scintigraphy, technetium-99 pertechnetate versus iodine-123. So, iodine-123 sodium iodide and technetium pertechnetate each have unique advantages and disadvantages for thyroid imaging. In routine clinical practice, technetium pertechnetate is the agent of choice for routine thyroid scintigraphy due to its widespread availability in all nuclear medicine laboratories. It's important to remember, however, that technetium pertechnetate is only a substitute for iodine, and it only reflects thyroid trapping at the level of the sodium iodide symporter expression and does not undergo further metabolism and organification. So practically, sodium iodide symporter, it's an ionic channel characteristic for the thyroid cell, which practically concentrates iodine against the intracellular gradient concentration in the thyroid cell. So technetium pertechnetate substitutes to iodine at the level of sodium iodide symporter, however, is not able to be organified by thyroid peroxidase and incorporated in the thyroid hormone synthetic pathway. Technetium pertechnetate, it's interpreted based on qualitative assessment of the image. Normal thyroid scan demonstrates homogeneous uptake in the thyroid gland, and the uptake should be similar or slightly higher than the salivary gland in a person in euthyroid status. So practically, this is a portrayal of thyroid scan in a person with normal thyroid hormone levels, and the qualitative image interpretation gives us a visual impression of the normal thyroid hormone levels based on the thyroid to salivary gland ratio assessment. So when the thyroid and salivary glands appear isointense, or thyroid uptake is just slightly higher than the salivary glands, that gives us an impression of normal thyroid function. This is a normal thyroid scan performed with iodine-123. Again, we can see homogeneous uptake of iodine-123 throughout the thyroid gland. And as we see in this image, the difference compared to technetium pertechnetate is that the iodine-123 scan image has a granular quality due to the fact that the amount of activity administered for obtaining this scan is much less. It's only 400 microcurie as compared to 5 millicurie for technetium pertechnetate, and also due to the fact that the images are obtained at 24 hours after radioisotope administration. Therefore, salivary glands are not visible in the image on the delayed images, because by 24 hours the iodine-123 has washed out of the salivary gland. So the interpretation of the scan is based on a qualitative assessment of the imaging regarding the thyroid to salivary gland ratio. A low thyroid to salivary gland ratio reflects the fact that the uptake of radiotracer within the thyroid gland is below that of the salivary glands, and this is consistent with thyroiditis, or possible with thyroid hormone treatment, which suppresses the uptake of radioisotope in the thyroid gland. So in conclusion, a low thyroid to salivary gland ratio is indicative of cellular damage due to inflammation at the level of the thyroid gland. Therefore, the thyroid gland is not able to hold up the radioisotope. In contradistinction, a high thyroid to salivary gland ratio means that the uptake within the thyroid gland is significantly above that of the salivary glands, and this is consistent with hyperthyroidism, which can be encountered in toxic diffuse goiter or toxic nodular goiter. In these cases, the salivary gland background uptake is poorly visualized. These are several imaging examples. In this case, as you see, the uptake in the salivary glands and in the thyroid, it's equal. So this is consistent with euthyroid status, normal thyroid hormone function. However, the abnormality here in this scan is the presence of a photopenic defect in the right thyroid lobe, consistent with a cold nodule. So here it's an image demonstrating presence of a cold nodule in a euthyroid patient. Similarly, in the right side of the image here, we have cold nodule in the left thyroid lobe. As you see, absence of any radioisotope uptake corresponding to this cold nodule. These images will have to be correlated with thyroid ultrasound, and since cold nodules have a risk of malignancy of 10 to 15% of cases in adult patients, these nodules will subsequently need to be evaluated with fine needle aspiration biopsy for definitive characterization. So in this case, it's an example of a solitary cold nodule on the right side of the image in the right thyroid lobe, and in the this side of the image in the left thyroid lobe. So qualitative evaluation of a thyroid scan. This is a normal thyroid scan. As you see, equal or almost equal salivary activity as compared to thyroid activity. So normal scan, salivary to thyroid gland ratio. While here it's a very abnormal scan with a very low thyroid uptake and high salivary radiotracer uptake. So this is consistent with a low thyroid to salivary gland ratio, consistent with thyroiditis. Again, qualitative evaluation. This is a normal scan, normal thyroid to salivary gland ratio. While here we have an abnormal scan with absence of visualization of the salivary glands and high thyroid uptake, which is very, very heterogeneous. So this is an abnormal scan with a high thyroid to salivary gland ratio consistent with hyperthyroidism, in this case toxic multinodular goiter. So regarding the quantitative thyroid function evaluation, this is performed by thyroid uptake testing, which utilizes either iodine 123 or iodine 131 sodium iodide. This is a good quantitative measure of thyroid function, determining iodine retention and organification in the thyroid gland. The thyroid uptake testing is used for calculation of therapeutic iodine 131 activity for treatment of hyperthyroidism. A normal uptake at 4 hours it's 3 to 9%, and the normal uptake at 24 hours it's 10 to 30%. Anything higher than 30% will be consistent with hyperthyroidism. Occasionally, technetium pertechnetate uptake is measured at the time of imaging. The range is 0.3 to 1.6. However, this is not a good quantitative measure of thyroid function, since it reflects only trapping and not organification, cannot be used for therapeutic iodine 131 dose calculation. So due to the fact that technetium pertechnetate has a rapid washout of the thyroid gland. So here is a comparison between advantages and disadvantages of technetium pertechnetate versus iodine 123 scintigraphy. Technetium pertechnetate has a gamma emission of 140 keV, has a short physical half-life of only 6 hours. We obtain high-quality images with low-energy, high-resolution collimator. It is a fast scan. Injection to acquisition, it's 20 to 30 minutes. However, technetium pertechnetate is just trapped in the thyroid gland at the level of sodium iodide importer. However, is not organified in the thyroid gland and therefore rapidly washes out of the thyroid gland. However, it's a good diagnostic tool because it's easily done and provides the clinician with a rapid diagnosis within 20 to 30 minutes of radiotracer injection. On the other hand, iodine 123 sodium iodide has it's a gamma emitter with 159 keV photon energy. Physical half-life of the radioisotope is somewhat longer than technetium pertechnetate at 13 hours. We still use low-energy, high-resolution collimator and use pinhole collimation for magnification of the imaging. However, the iodine 123 scintigraphy, it's a 2-day scan protocol with both scan and thyroid uptake obtained early at 4 to 6 hours and then delayed at 24 hours. It's a costly radioisotope, both from the standpoint of the price of radioisotope itself and also due to the dual time 2-day procedure. Therefore, iodine 123 is considered especially for children and on special request when an organification defect is suspected. And I will present here a case of suspected organification defect in a 46-year-old woman who has multiple thyroid nodules in the thyroid gland occurring in the context of remote radiation exposure of the neck and chest for treatment of Hodgkin disease at age 17. So there is, in this case, there is clearly a concern for radiogenic induced thyroid cancer. This patient obtains regular follow-up with neck ultrasound for surveillance of multiple thyroid nodules that involve both lobes. And what is suspicious is that there is a right thyroid lobe nodule that has increased significantly as compared to a prior neck ultrasound done 1 year ago. So these nodules, it's located in the inferior right thyroid lobe, while the other nodules in the left thyroid lobes appear stable. These are the thyroid function tests that show euthyroidism, normal TSH. However, the patient is on thyroid hormone supplementation with Synthroid 100 microgram daily for nodule growth suppression. And here is the technetium scan. So as we see, the technetium pertechnetate scan shows increased radiotracer uptake in the inferior pole of the right thyroid lobe at the site of the nodule that showed suspicious growth on surveillance neck ultrasound. So due to the fact that this nodule is growing, however, shows increased isotope uptake, here it's exactly the conundrum of a possible organification defect in which the technetium pertechnetate is trapped but may not be organified, and this apparently hot nodule may actually harbor a thyroid cancer. So in this case, for more accurate diagnosis, because of the discrepancy between an image of a hot nodule on the pertechnetate scan and the fact that this nodule is suspicious on ultrasound due to interval growth, in this case, iodine 123 scan was ordered to assess for a possible organification defect. And here is the iodine 123 scan, early image obtained at 3 hours. As we know, the iodine 123 scan, it's a dual time imaging, early imaging at 3 to 4 hours and delayed imaging at 24 hours. This is the early image presented, and as you see, the image is very, very similar to the technetium pertechnetate image presented previously. Again, we see this inferior right thyroid lobe hot nodule appears hyperfunctional. However, on the delayed image that is presented in this panel, we see that the radioisotope washes out on delayed imaging. So a summary slide presents the technetium pertechnetate image at 20 minutes, showing apparently hot nodule in the inferior pole of the right thyroid lobe, very similar to early image at 3 hours with iodine 123 scan. However, on delayed imaging at 24 hours, the concentration of radioisotope corresponding to this inferior right thyroid lobe nodule has washed out, and this is entirely consistent with a discordant nodule on early imaging and delayed imaging, or a discordant nodule between technetium pertechnetate and delayed imaging iodine 123 scan, entirely consistent with an organification defect. So, thyroid imaging protocols. So, the study protocol begins always with the patient preparation. So, being cognizant of the patient clinical situation, laboratory tests, and also having a knowledge about medications that this patient is taking. So, for pure diagnostic imaging with technetium pertechnetate, there is no need for any special preparation. However, a knowledge of the medications is very important for interpretation of the imaging. Most of the time, the study, the technetium pertechnetate scintigraphy, is ordered in conjunction with an iodine 131 thyroid uptake scan, abbreviated here as a radioactive iodine uptake, RIU testing, as a part of the two-day study. So if the iodine 131 uptake is ordered, then patients should be off antithyroid medications such as methimazole or propylthiouracil for 1 week in order to reflect accurate internal endogenous thyroid state, and also in preparation for radioactive iodine therapeutic administration. So here it's actually a list of the compounds that may decrease thyroid iodine uptake, such as the corticosteroids, definitely the antithyroid medications used for treatment of hyperthyroidism, such as methimazole or propylthiouracil. Also, thyroid hormone preparations such as cytomel and synthroid may decrease thyroid uptake due to decreasing or suppressing TSH level. Of course, kelp preparation, intravenous contrast agents should be delayed. The imaging should be delayed for 4 weeks in order to allow the intravenous iodine contrast load to be eliminated. But this is again only in the case in which the technetium pertechnetate scintigraphy is done in conjunction with thyroid uptake testing in preparation for therapeutic administration of radioactive iodine for thyroid ablation procedure. If only diagnostic imaging with technetium pertechnetate is requested by the clinical service, then in that case, no special patient preparation is required. However, the radiologist needs to be informed about the medications that the patient is taking in order to provide interpretation of the scan in the correct clinical context. So, functional thyroid imaging. So, the thyroid scan pinhole is done on the first day with intravenous injection of 5 millicurie technetium pertechnetate intravenous administration. This is a 20 to 30 minutes imaging protocol. Immediately after radiotracer injection, it's done with a pinhole collimator, obtaining imaging in anterior projection and right and left lateral oblique projections. Images are obtained with and without markers on the chin and suprasternal notch, usually for acquisition to 100,000 counts. The radioiodine uptake testing can be obtained at the same time by administering 7 to 10 microcurie of iodine-131 as oral administration. This is performed for patients referred for thyroid ablation procedure. So the test uptake testing is started on day 1, immediately after the thyroid scan is completed, and completed on the second day, day 2, when we measure 24-hour iodine-131 retention in the thyroid gland by the uptake probe, and the number that is obtained is used for calculation of therapeutic iodine-131 activity. So the interpretation of the thyroid scan, a normal gland, it's a butterfly-shaped gland with uniform radiotracer distribution in the both thyroid lobes. And as you see, the uptake in the thyroid gland as compared to salivary glands should be very similar or slightly higher as compared to the salivary gland background. We look at the size and morphology of the thyroid gland, looking for abnormal enlargement or abnormal shape of the thyroid lobes, and we compare the uptake in the thyroid gland with the salivary glands. We also look for nodules, if there are any cold nodules consistent with hypofunctioning or non-functioning nodules. These have a chance of 10 to 15% of being malignant, therefore correlation ultrasound and subsequent final aspiration biopsy is recommended depending on the TIRADS classification. And alternatively, we can see hot thyroid nodules consistent with hyperfunctioning nodules, which are in great majority of cases, 99% of cases, benign. So they do not require further investigation with ultrasound and biopsy. And sometimes we have warm or iso-intense thyroid nodules within a normal thyroid gland. This may be potentially a cold nodule with superimposed a layer of normal thyroid tissue. Therefore, a SPECT-CT imaging should be acquired for more accurate characterization. This is a case of an 18-year-old woman presenting with depression, anxiety, falling grades at school, abdominal cramps, and variable moods. And this is a typical image of Graves' disease with a very, very high radioactive iodine uptake of 87%. As mentioned before, the upper limit of normal for thyroid uptake is 30%. So this is very intense hyperthyroidism. And we see this patient image with iodine-123 scan showing diffuse homogeneous radiotracer uptake throughout an enlarged thyroid gland bilaterally. And this is a comparison with a technetium pertechnetate scan obtained in the same patient after intravenous injection of technetium pertechnetate. As you see, the images appear very similar, homogeneous distribution of radiotracer throughout an enlarged thyroid gland. So, thyrotoxicosis, the symptoms of hyperthyroidism are derived from an increased metabolism affecting most organs, and is characterized by anxiety and nervousness, tremolousness, weight loss with increased appetite, rapid heart rate, tachycardia, increased frequency of bowel movements, hyperthermia with a preference for cool temperature, increased sweating, irregular menstrual periods, fatigue, weakness, inability to concentrate, and therefore falling grades at school. So this is next case presentation of a 59-year-old man with palpable right thyroid nodule. The neck ultrasound shows a heterogeneous solid nodule with increased peripheral vascularity in the inferior aspect of the right thyroid lobe, measuring almost 1 centimeter, grossly stable as compared to a prior exam. However, thyroid function testing, as depicted in this table, showed suppressed TSH and elevated T3 above the upper limit of the normal range. And this is the image correlation. And as we see, there is a diffuse homogeneous uptake throughout both lobes of the thyroid gland with increased thyroid to salivary gland ratio, clearly salivary glands are a much lower level of activity as compared to the thyroid gland. This gives us an impression of thyrotoxicosis. And what is remarkable here is the presence of a cold or photopenic nodule in the inferior pole of the right thyroid lobe. So in this case, we have Graves' disease and a cold thyroid nodule. So in this case, the thyrotoxicosis is due to Graves' disease. However, we have a second pathophysiology here of a hypofunctional nodule in the right thyroid lobe. So a cold nodule in Graves' disease. So palpable nodule in Graves' disease happens in approximately 15% of Graves' disease patients, and the incidence increases with duration of Graves' disease. So in a series of 468 patients published by Carnell, approximately 6% of patients had solitary cold nodules, and out of these, 20%, almost 20%, contain cancer. So in a cold nodule in the setting of Graves' disease should always be investigated with a fine needle aspiration biopsy in order to rule out malignancy. This is a companion case of a patient with a large palpable left thyroid nodule. As we see, the scan shows clearly enlarged left thyroid lobe, which concentrates the radioisotope at much lower level as compared to the contralateral lobe. And we can notice from this image that there is significantly increased thyroid to salivary gland ratio consistent with hyperthyroidism. In addition, we have actually a very faint uptake in the midline neck consistent with a thyroglossal duct remnant tissue, which is activated in the setting of Graves' disease by the presence of TSH receptor activating antibodies, or TSI, thyroid stimulating immunoglobulin. So in this case, this is another case of a patient with Graves' disease, thyrotoxicosis due to toxic diffuse goiter, and a very abnormal left thyroid lobe nodule encompassing the entire left thyroid lobe. And in this case, fine needle aspiration biopsy demonstrated the presence of papillary thyroid cancer. So in this case, patient was referred for total thyroidectomy that will address at the same time the treatment for thyroid cancer and treatment for thyrotoxicosis by surgical resection of the thyroid gland. So next case demonstrates the presence of a hot thyroid nodule in the superior aspect of the left thyroid lobe. The contralateral lobe is not entirely suppressed. So the nodule is hyperfunctioning, but at a low level, with resulting in just a borderline suppression of TSH, and therefore the remaining thyroid parenchyma in the contralateral lobe and inferior part of the left thyroid lobe is not completely suppressed. A companion case, it's a 55-year-old woman presenting with palpitations. This scan shows the presence of an autonomous nodule in the inferior pole of the right thyroid lobe without suppression of the remainder of the thyroid gland, and ultrasound correlation clearly describes the presence of 2.1 by 1.3 by 1.4 centimeter solid nodule in the inferior thyroid lobe. In this case, thyroid scan is very informative, telling us that this is a hyperfunctional nodule. The risk of thyroid cancer is minimal. These nodules are in overwhelming majority benign, so biopsy does not need to be performed. And in the clinical context of palpitations, this patient will need treatment with beta blocker and subsequent discussion regarding definitive treatment option, either with radioactive iodine thyroid ablation versus surgical management. Here is a case of nodule, hyperfunctional thyroid nodule, autonomous thyroid nodule in the left thyroid lobe with complete suppression of the contralateral lobe. This is an image with markers placed in the neck. This is an image, like pinhole image, without markers, clearly showing the hyperfunctional nodule encompassing the left thyroid lobe and complete suppression of the contralateral right thyroid lobe. 31-year-old woman presenting with abrupt onset of depression, insomnia, anxiety for 6 months. She has mild subclinical hyperthyroidism. The TSH is suppressed at 0.26. We see a large hyperfunctional thyroid nodule in the left thyroid lobe with almost but not complete suppression of the contralateral right thyroid lobe. This is a companion case, a 34-year-old woman with cramps and diarrhea, with subclinical hyperthyroidism, mildly suppressed TSH with normal T4 and T3 level. As we see, there are multiple nodules here. We have 2 distinct nodules, one in the medial aspect of the right thyroid lobe and another nodule in the isthmus. Here it's an image with markers placed on the surface of the skin, showing a distance of 5 centimeters apart, while this is an image without markers, showing multinodular goiter, practically with suppression of the left thyroid lobe. The nodules are present in the right thyroid lobe and isthmus. Atypical presentation of hyperthyroidism. This is the case of a 22-year-old woman with uncertain clinical symptoms. She has headaches, proximal muscle weakness, and tremor. Her palms are hot and sweaty, and she is tachycardic. Due to severe proximal myopathy, she is suspected to have myasthenia gravis or a neurodegenerative disorder, and an incidentally detected pituitary incidentaloma on a brain MRI. As you see here, the TSH is suppressed, T4 is normal, and thyroid-stimulating immunoglobulins are undetectable. Thyroid scintigraphy demonstrates the presence of a very large hyperfunctional left thyroid nodule, which has a photopenic center consistent with degeneration of the central portion of the nodule due to outgrowth of vascular supply. So practically the nodule is peripheral hyperactive with a central core of degeneration. The image is typical of thyrotoxicosis due to suppression of the contralateral lobe and very low salivary radiotracer uptake, so consistent with increased thyroid to salivary gland ratio. And here is another demonstrative image of multinodular goiter. This is an image with markers placed on the chin and suprasternal notch. And this is an anterior image, pinhole collimation without markers, showing the multitude of thyroid nodule involving bilateral thyroid lobes. And another image very typical of multinodular goiter, demonstrating heterogeneous radiotracer uptake throughout the thyroid gland, consistent with hyperfunctional nodularity. So destructive thyrotoxicosis, it's as we discussed at the beginning, it's distinct from hyperthyroidism. Destructive thyrotoxicosis is due to leakage of preformed thyroid hormone from thyroid gland due to inflammation. These are the conditions that lead to destructive thyrotoxicosis. This is painful subacute or decurvent thyroiditis. Also postpartum or sporadic silent thyroiditis occurring within 3 to 6 months after delivery. Hashimoto thyroiditis and in the destructive phase. Also, we have medication-induced thyroiditis such as lithium thyroiditis, interferon alpha thyroiditis, and type 2 amiodarone-induced thyroiditis. And also, there are cases of thyroiditis, acute thyroid inflammation due to trauma, surgical manipulation, palpation, or irradiation, resulting in follicular cell injury and release of stored thyroid hormone. So this is an image of thyroiditis. As you can see, there is a very low thyroid to salivary gland ratio. The uptake in the salivary gland is much higher as compared to the thyroid. So this is a low thyroid to salivary gland ratio, entirely consistent with thyroiditis. This is a case of subacute thyroiditis. The 24-hour uptake measurement is confirmatory, showing an uptake less than 3 to 5%. Subacute thyroiditis, usually the most common cause is either viral or postpartum thyroiditis. It's inflammation of the thyroid gland with massive release of thyroid hormone in the bloodstream, causing transient thyrotoxicosis. The thyroid gland often becomes depleted of thyroid hormone as the course of inflammation continues, leading to a fall of thyroid hormone levels in the blood and symptoms of hypothyroidism. So practically there is a triphasic evolution of thyrotoxicosis, starting with high levels of thyroid hormones, then low levels of thyroid hormone due to the exhaustion of the thyroid hormone reservoir in the thyroid gland, and then finally the third phase of recovery to normal thyroid function. So hyperthyroidism, hypothyroidism, followed by recovery. And usually this three-phase evolution lasts 3 to 4 months. What causes thyroiditis? Usually it's an autoimmune process, such as in postpartum thyroiditis, and patients with a background of Hashimoto thyroiditis. Could be also a viral infection, like in subacute of thyroiditis. Can be radiation-induced thyroiditis in patients who underwent external beam radiation therapy to the head and neck, or in patients with treatment with radioactive iodine. And also drug-induced thyroiditis, such as amiodarone, lithium interferons, or cytokine treatment. And here it's a very good example of type 2 amiodarone-induced thyroiditis. As you see, it's no evidence of radiotracer uptake at the base of the neck. It's very faint. It's absent uptake at the expected location of the thyroid gland, consistent with thyroiditis. So regarding amiodarone-induced thyrotoxicosis, amiodarone is an iodine-rich drug that is used to treat arrhythmias. In addition to hypothyroidism, amiodarone can also cause thyrotoxicosis. So there are two types of amiodarone-induced thyrotoxicosis. It's type 1 amiodarone-induced thyrotoxicosis due to increased production of thyroid hormone due to increased supply of iodine to in a patient with a background of multinodal goiter. The second type of amiodarone-induced thyrotoxicosis is type 2, which is due to increased release of thyroid hormone due to a cell-damaging effect of excessive iodine concentration in the thyroid gland. So amiodarone induced thyrotoxicosis, it's very important to discern if type 1 or type 2 is present in order for adequate treatment. Type 1, it's treated by anti-thyroid hormone medications, while type 2 is treated by administration of corticosteroids and anti-inflammatory medications. So imaging plays an important role for differentiating type 1 or type 2 amiodarone-induced thyrotoxicosis. It's very useful for the clinicians, this characterization as type 1 or type 2. Technetium sestamibi, it's used for this characterization of type 1 or type 2. Technetium sestamibi is a mitochondrial agent, which can give us insight regarding the etiology of amiodarone-induced thyrotoxicosis. And as you see in type 1 amiodarone-induced thyrotoxicosis, there is preserved thyroidal technetium sestamibi uptake. You can see there is technetium sestamibi uptake above the salivary gland ratio. There is an increased thyroid to salivary gland ratio. This is consistent with type 1 amiodarone-induced thyrotoxicosis, consistent with thyroid autonomy due to excessive iodine supply in amiodarone, as opposed to type 2 amiodarone-induced thyrotoxicosis, which shows decreased thyroidal sestamibi uptake as compared to salivary gland. So this is excessive thyroid hormone release due to cell-damaging effect of severe iodine load in the thyroid gland, consistent with type 2 amiodarone-induced thyrotoxicosis. The second part of my presentation will address the thyroid cancer scan imaging. Well-differentiated thyroid cancer is able to trap iodine, but significantly less so compared to normal thyroid tissue. In the presence of normal thyroid tissue, malignant tumors appear as cold nodules. However, after total thyroidectomy for primary treatment of thyroid cancer and after preparation with low iodine diet and TSH stimulation, iodine-131 scan is performed to detect and treat thyroid cancer. So this preparation with low iodine diet and TSH stimulation is absolutely required for optimizing iodine uptake in the neoplasm and to increase radiation absorbed dose to tumor. So these are the indications for iodine-131 thyroid cancer scan. It is always performed after total thyroidectomy. The first indication is for postoperative disease staging, for detection of regional and distant metastases after primary resection. The second indication is to assess residual thyroid tissue after total thyroidectomy and for guiding therapeutic iodine administration for treatment of thyroid cancer. It's the blending of the concept of diagnostic and therapeutics as outlined in the word of theranostics, which is therapeutics guided by diagnostic imaging performed with the same isotope. The iodine-131 scan requires special preparation to optimize scan quality and improve therapeutic targeting of iodine-131. The low iodine diet preparation is required for reducing the stable iodine load from the body. The length of low iodine diet is preferable for 2 weeks for good preparation. The second preparation is obtaining TSH elevation above 30 millunits per liter, which is obtained either by thyroid hormone withdrawal or by injection of recombinant human TSH in the thyrogen stimulation protocol. Here is an example of a thyroid scan, thyroid cancer scan performed with iodine-131 after oral administration of 4 millicurie of sodium iodide, iodine-131 sodium iodide. And as you see, the distribution of iodine throughout the body is very typical. We have uptake in the salivary glands and mouth due to salivary excretion of iodine-131. We have significant uptake in the central neck at the site of the thyroidectomy bed, and then physiologic radiotracer distribution throughout the bladder with activity present in the stomach, bowel, bladder, consistent with urinary excretion of radioisotope. This scan is very important for detection of regional and distant metastases. So evaluation of the chest and the entire skeleton, the entire body is required to assess for presence of pulmonary and distant metastases, which in this case are absent. Usually a whole body scan, a sweeping view of the body from the vertex to the toes is obtained, accompanied by a spot view image of the neck and chest for assessing for abnormal uptake in the neck or lungs. Classically, an anterior pinhole image of the neck was obtained in order to increase spatial resolution and further characterize the focal activity present in the neck. And in this case, as we see, the pinhole image characterized this focal intense activity as 4 distinct foci of activity in the neck, very typical bilateral thyroid bed, remnant, thyroglossal duct remnant, and some focal activity, much fainter activity in the right neck. So the interpretation of the scan, it's based on recognition of normal iodine accumulation in the salivary glands, nasopharynx, tip of the nose, breast, bladder, stomach, and small and large intestine. There is residual thyroid tissue remaining after total thyroidectomy, and seen as thyroid bed uptake, often asymmetric, and also thyroglossal duct remnant uptake in the midline central upper neck. Here it's an example of thyroid remnant tissue, diagnostic iodine scan performed with a spot view of the neck, and as we see, there is uptake in the central neck compartment, midline thyroglossal duct tissue. Here also right thyroid bed remnant tissue. There is physiologic uptake in the parotid salivary glands, physiologic uptake in the nasal passages, and here is actually iodine adhesion to metallic dental material found in the mouth, dental amalgam. The iodine scan interpretation, postoperative, there is never absolute complete resection of the thyroid gland. Total thyroidectomy is a near total resection because in order to prevent inadvertent injury to recrolaryngeal nerve in the tracheoesophageal groove, the surgeon will leave a small amount of normal thyroid tissue remnant in the paratracheal area at the level of the thyroid bed. The thyroid remnant tissue is interpreted in the context of risk. We'll put together the imaging findings with the results of biochemical testing, specifically detection of thyroglobulin level, which is used as a tumor marker for thyroid cancer, and also we'll look at the high-risk pathology features such as positive surgical margins, extrathyroidal tumor extension, and presence of nodal metastasis in the surgical resection specimen. We'll look for regional and distant metastases which concentrate iodine, and usually SPECT-CT is used as a problem solver. Here it's actually utilization of SPECT-CT imaging for characterization of the thyroid tissue seen in the central neck. So in order to differentiate thyroid remnant tissue versus nodal metastasis, SPECT-CT is very, very useful. As you see, this is the CT and this is the SPECT-CT fused image showing focal uptake in the tracheoesophageal groove at the level of bilateral thyroidectomy bed. Here it's a sagittal view showing the uptake in the tracheoesophageal groove at the site where the surgeon left a small sleeve of thyroid remnant to protect the recrolaryngeal nerve and parathyroid gland. And also there is this focal uptake in the midline upper neck centrally, consistent with thyroglossal duct remnant. And a very nice image of this activity here at the tip of the thyroid cartilage here, consistent with residual functional thyroid tissue in thyroglossal duct remnant, and this should not be confused with metastatic thyroid cancer. This is normal tissue that can be ablated with low activity iodine-131, does not require iodine-131 therapy escalation because benign tissue has very high density and activity of sodium iodine importer expression, so therefore low activity iodine-131 it's quite sufficient for remnant ablation. However, SPECT-CT can help us clearly differentiate remnant ablation from residual thyroid cancer. For example, in this case, the CT correlate clearly shows hypodense lesion with clear activity on the SPECT-CT, very abnormal as compared to contralateral side. This is entirely consistent with residual tumor in the left neck, which will be amenable to treatment. Here it's an example of radioiodine theranostics. So the utilization of diagnostic iodine-131 scintigraphy for guiding iodine-131 treatment in the setting of metastatic disease. So this is the case of a 32-year-old woman who has a 1.8 centimeter follicular variant papillary thyroid cancer in the left lobe, positive surgical margin. She has high-risk pathology. A lot of lymph nodes were resected from the central neck and the left lateral neck. Postoperatively, the patient is made hypothyroid, and biochemical testing reveals very high level of thyroglobulin consistent with residual tumor burden. And this is confirmed by the scintigraphic imaging evaluation showing the presence of diffuse bilateral pulmonary metastatic disease as portrayed by this heterogeneous radiotracer uptake in both lungs. And also we have residual thyroid cancer in the neck as demonstrated by the presence of this very intense focal activity in the left lateral neck in addition to thyroid remnant tissue. But very striking, we have evidence of metastatic disease involving the skeleton, as demonstrated by this metastasis in the calvarium and in the right pelvis here. SPECT-CT imaging definitely helps with the further characterization. This is focal activity demonstrated in the right pelvis. The SPECT-CT helps us practically pinpoint this metastasis in the right pubic bone. This would be very hard to detect on CT alone because the cortex it's intact. So this detection of early metastatic disease before the cortex of the bone is destroyed by the metastatic process. Again, here it's a similar image of a very small metastasis in the vertebra, one of the lower thoracic vertebral body, without evidence of cortical bone destruction. However, the focal activity is clearly consistent with iodine-avid metastatic thyroid cancer. Similarly, the osseous metastasis in the calvarium. And this is actually a very important portrayal of the usefulness of functional imaging, which is able to detect metastatic disease at an earlier stage before anatomic changes in the bone occur. Here it's the identification of multiple sub-centimeter pulmonary nodules, and based on all these findings, including the presence of regional metastatic disease, this is a residual lymph node remaining in the left neck in association with surgical clips at the site of the previous left neck dissection. So based on all these findings, the patient underwent dosimetry calculations and was treated with escalated radioactive iodine treatment at 320 millicurie for targeting this pulmonary and osseous metastatic disease. Another case demonstrating the theranostic usefulness of diagnostic iodine scan in thyroid cancer is the case of this 45-year-old man who underwent total thyroidectomy for resection of a 3.4 centimeter papillary thyroid cancer. He had multiple lymph nodes resected, practically 58 lymph nodes resected, out of which 30 were involved with metastasis in the bilateral neck. However, the post-total thyroidectomy diagnostic scan demonstrates the presence of residual metastatic lymph nodes unexpectedly here in the central neck compartment, which is clearly demonstrated on SPECT-CT here at the sternal notch. This is not thyroid remnant tissue. This is clearly metastatic disease corresponding to small lymph nodes at the sternal notch and also in the left supraclavicular area here identified in the coronal image. So in this case, the patient was referred to surgery prior to radioactive iodine treatment. Thank you for your attention.